Okay, good morning. So we just want to demonstrate examination of the abdominal system. Now, when you examine the abdomen, as with other systems, you're going to find that there are a number of ways to do it. But we want to focus on the way which will have the most effective technique to detect the abnormalities. If you do come across any variations, please discuss them with the consultant on service. Now, to start with the examination, the first thing you want to do is to have the patient on the bed. You want to make sure that the patient is willing to do the exam. So the first thing is always to introduce yourself to the patient. Come to the patient's side. Good morning, sir.
Morning.
I'm Dr. Mills. I'm one of the consultants at the hospital here, and I'd like to examine your abdomen. What's your name?
Giovanni Henry.
Hi, Mr. Henry. Is that okay with you?
Yes, Doctor.
Okay. So once you get permission from the patient, the next thing you want to do is to expose the area adequately. Now for males, it's a lot simpler. You want to take the sheet and just move it down to the level of the SIS bilaterally, so you can see the inguinal area. For females, you may leave the brassiere on, covering the breast, or a small towel to cover the breast in the initial stage of the examination. But ultimately, you will need to expose that area also for females. Then you're going to stand at the foot of the bed, and the first thing you want to do is inspection. Now, when you're inspecting, you want to make sure that you inspect all the areas of the abdomen for symmetry. Just turn both hands out for me. That's right. And from the foot of the bed, you want to get down to the level and inspect the abdomen to see if there is symmetry or any evidence of fullness in any areas of the abdomen. If the abdomen is globally distended, is it flat? Is it full in one area? Is the bladder more prominent? Is there a fullness in the epigastrium? You want to inspect the umbilicus to see if it's flattened or if it's inverted or everted. You want to look for any obvious scars, if there are surgical or traumatic scars. You want to describe those scars, the location, for example. You want to look for the hair distribution to see if it's a normal male distribution of hair. And you also want to look to see if you have any abnormal dilated veins. In particular, you want to look around the umbilical area to see if veins which dilate from this area, what's described as a caput medusae, is due to portal hypertension. You may also see evidence of peristalsis on the abdominal surface if the patient is very thin or if they have intestinal obstruction. But this is not something that we commonly look for. Once you've finished with your inspection, the next thing you want to do is some palpation. Now, depending on the height of the patient to you, you may need to sit for the examination. It's important to sit if the patient is too low. What you want to make sure is that your hand is basically horizontal at the wrist. You don't want to have an angle, because that's going to make the examination very difficult. So this is not the correct technique. You want to make sure the hand is as straight as possible when you're palpating. Now, before you start palpating, you want to ask the patient if they're having any pain anywhere.
No, Doctor.
If they're having pain anywhere, you want to focus on the area furthest away from the pain as much as possible to make the examination more comfortable for the patient so they're not too apprehensive. But you still need to examine the area that has pain to make sure that you can find what the pathology is. Now, palpation normally has two facets to it. There's light palpation and deep palpation. For light palpation, you're going to feel to see if there are any areas of tenderness and if there are any obvious masses. You want to select an area of the abdomen. It's very random. You can divide the abdomen into 9 quadrants if you like and start in one quadrant furthest away from the pain, but just do it in a systematic fashion to cover all the areas. So you're going to start, for example, in the right lower aspect. Now, when you're palpating, you want to keep an eye on the patient's face to see if you're causing any discomfort. And you're just going to palpate lightly. And the palpation basically involves flexing at the metacarpophalangeal joints to make sure that you're not pressing too hard. You don't want to be doing this kind of movement. And you don't want to be causing undue discomfort to the patient. Just feeling in the area to see if there's any abnormality at the surface. Now, if they're having any unusual masses, you're going to note what those masses are in your mind, because you're going to come back and examine them in more detail, describing what the location of the mass is and the consistency of the mass, the dimensions of the mass. and so on. But for light palpation, as I said, you're going to focus on one area, just palpate in the different quadrants, divide the abdomen up, make sure you're consistent, not to miss any areas, examine the patient's face for any evidence of tenderness, and then report your findings. So if the abdomen is normal, for example, you report that this patient on light palpation, he did not elicit any tenderness or feel any masses. The next aspect is deep palpation. What you want to do is tell the patient, I'm going to press a little harder. I'm not going to try and cause any pain. When you palpate more deeply, it's the same technique as for light palpation, but you want to press much further down into the abdomen to feel any deeper masses. Again, paying attention to the patient's face to make sure that you're not causing undue pain, and to try and elicit any tender points which may reveal pathology. Again, if there is any evidence of any deep masses, you want to note where they are, and also to describe them if you can in terms of the surface of that mass and the dimensions of the mass, consistency, and so on. After light and deep palpation, you're going to go for specific organs. You're going to start with the liver, which is on the right, in the right upper quadrant. To palpate for the liver, first thing you want to do, once again, is decide which aspect of the border of the hand you're going to use. Now, we tend to encourage using the lateral border of the index finger to palpate for the liver, starting in the right iliac fossa. You can also use the fingertips. There's nothing wrong with using the fingertips to palpate, but we're going to focus on using the border. I'm going to start in the right iliac fossa, ask the patient to take a deep breath in and let the breath out. When you take a deep breath in, the organ moves down to meet the examining hand. And that's the point where you're going to, if you feel the mass, just gently try and appreciate what the surface of the mass feels like, the edge of the mass, and so on. So you're going to try and coordinate your hand movements with this breathing. Take a deep breath in and out for me. So he breathes in, he breathes out. When he breathes out is when you move up to the next point. Breathe in and out for me. And you're just going to feel along until you actually meet either the costal margin or an abnormal liver edge. Now in this instance where we did not feel a liver edge, obviously we've reached the costal margin, so that would be the end of the palpation aspect. If we had felt a liver edge a little further down, for example, if the liver had been felt here, then we'd be able to feel the edge of the liver using the fingertips gently to see what the extent of the liver is, to see if it extends, for example, into the left upper quadrant of the left lobe, which may be enlarged in that area. You're going to feel over the liver gently to see if the surface is smooth or if it's irregular, if there are any nodules on the surface. You're going to look to see if there's any tenderness over the liver, looking at the patient's face as you press down to see if there's any tenderness. And you also want to determine if the consistency of the liver is hard or soft, or if it's just firm, which is normal. After you've identified what the liver feels like on palpation, the next thing you want to do is percuss to see what the liver span is like. Percussion involves, again, the typical technique. You're going to start in the right iliac fossa. You want to place your finger down in the mid-clavicular line. The middle finger is going to be percussed. Usually we want to encourage you to use just 2 taps, and you want to listen to see if you're going to hear a change in the percussion note. So when the percussion note becomes dull, that signifies the lower border of the liver. So when there's a change in the note, you ask the patient to take one finger and just note that point where you thought that note changed. Then you're going to come up below the clavicle on the right side in the mid-clavicular line, the same line, and you're going to percuss in the intercostal spaces until the note changes. And as the note changes, again, you're going to note the upper border of the liver. You're going to take your tape measure, which I don't have in this case, but you're going to measure this distance. Now, if you don't have your tape measure, what you need to do is to know what the distance is from the tip of the index finger to the base of the thumb. Measure that distance at home and measure each of the distances of each of the phalanx. And then estimate what the span of the liver is. And the normal liver span, as you know, is from 9 to 11 centimeters. So once you identify the span of the liver, you know the characteristics of the liver, you can give a differential diagnosis if you think the liver is enlarged or if it's small. After you finish with palpation of the liver, you want to go for the spleen. Now, when you examine for the spleen, again, you're going to start in the right iliac fossa, and you're going to palpate. Now, it's more acceptable to use the tips of the fingers to palpate for the spleen, going across the umbilicus. Again, it's not necessary to ask the patient to take deep breaths in and out. What you want to do is to palpate until you feel either the edge of the spleen or the left costal margin. Once you feel the left costal margin, which means that you're not palpating an enlarged spleen, you're going to follow the costal margin all the way laterally, because the spleen can enlarge either in a diagonal direction or inferiorly towards the left iliac fossa. If you do not feel the spleen of the patient flat, ask the patient to turn towards you, turn on the side towards me. Now, you can ask the patient to rest their hand on the shoulder, which can be done. Sometimes it's not as comfortable for the patient or yourself, or more comfortably ask the patient to just rest their hand here at the side of the bed. You're going to support the patient at the back with your left hand, and you're going to start palpating from the midline towards the left costal margin, trying to feel a spleen which is just enlarged. So you're going to palpate along the costal margin to see if you can actually feel that spleen. And as the patient take a deep breath in for me, and as the patient breathes in, you just feel lightly along the costal margin to see if that spleen becomes palpable. If it's still not palpable, you're going to start percussing as well for the spleen. With the patient in this position, you're going to percuss from the umbilical point. You're going to percuss towards the costal margin until you get dullness. So normally all of this will be resonant. It will be resonant up to the mid-axillary line. So if there is any dullness anterior to that aspect, it suggests the spleen is enlarged on percussion, even if it's not palpable. You expect the normal spleen to be sitting posterior to the mid-axillary line in the 9th to 11th intercostal spaces. So once again, if you don't feel the spleen when the patient is flat, turn them on the side towards you. You're going to palpate towards the costal margin. Ask the patient to take a deep breath in, and then palpate in the area to see if you can just tip the spleen. If you're not able to feel the spleen, you're going to start percussing for the spleen as well, and you're going to percuss to the point where it becomes dull, or until you hit the mid-axillary line. If it's resonant to that, it means the spleen is normal. If you do feel an enlarged spleen, you need to measure the diameter of the spleen. You want to measure from the costal margin, ideally in a direction towards umbilicus. So in perpendicular to the direction of the costal margin, you want to take a tape measure and just measure this distance. For example, the spleen would be 3 or 4 centimeters below the left costal margin. If you choose to measure it in this direction, directly down in the axillary line, then you have to note that you've measured it in that plane, so that whoever is measuring it after you knows which dimension you're measuring the spleen in. After you finish with the spleen, the next thing you want to do is to examine for the kidneys. So right and left kidneys, both of them are retroperitoneal structures. What you want to do is palpate for the kidneys initially. When you palpate, it's by manual palpation. So you want to place one hand posteriorly in the renal angle, which is located just in the paravertebral space and below the costal margin posteriorly. And the other hand is going to be placed over where you think the kidney is. Now the kidney is going to be somewhere related to the hilum of the kidney, which is 2.5 centimeters laterally and superiorly from the umbilicus. So if you know the hilum is here, then you suspect the kidney is going to be somewhere in this area. So you place one hand anterior to where the kidney is, the other hand is posterior in the renal bed. First thing you want to do is just compress lightly and ask the patient to take a deep breath in and out for me. And you check to see if you can feel an enlarged mass sliding between the two hands. Now ordinarily you're not going to feel the kidney unless the patient is very thin. The next move you want to do is, as you're compressing bimanually, is just to ballot for the kidneys. So to ballot the kidney, you want to move the posterior hand superiorly repeatedly to try and bounce the kidney against the hand anteriorly, which is not moving. So the hand posteriorly is the one which is moving up like this, and the kidney should come and hit your hand if it's enlarged. Next thing you want to do is repeat the maneuver on the opposite side. So you want to put this hand in the renal bed, this hand anteriorly where you think the kidney is, and ask the patient to take a deep breath in and out to see if you can feel the kidney sliding between the hands. And then you want to also do a ballotting maneuver to see if you can ballot the kidney on that side. Sometimes in very thin individuals, the left kidney may be felt more prominently. The other thing you want to do after you finish with the kidneys is to check for the presence of ascites. And that's done by checking for shifting dullness. If the patient's abdomen is grossly distended, it suggests that there is ascites, especially if the umbilicus is everted. But even if the abdomen is flat, there may still be ascites. What you have to do is to check for shifting dullness by percussion. You're going to place one finger down at the umbilicus to start, and you're going to percuss towards you. Now you're going to percuss to the point where you get dullness. So normally there will be resonance throughout. Let's say, for example, the patient has ascites. This became dull here. You're going to note and say, yes, there's dullness on one side. You go back to the midline. You're going to percuss again to the opposite side to the point where it becomes dull. Leave your finger at that point and ask the patient to turn towards you. Turn towards me. And as the patient turns towards you, then the fluid should shift. So the fluid is going to now move in this direction, leaving this point resonant. So you're going to percuss at the point where it was resonant and becomes, or it was dull, sorry, and it becomes resonant. You're going to percuss towards the umbilicus until it becomes dull. Ask the patient to lie flat at that point. The fluid should shift away, and then you're going to percuss again at that point to show that it becomes resonant. So you have demonstrated that there is shift of fluid. Okay, so briefly again, patient's abdomen is in front of you. You're going to percuss from the midline, first towards you to the point where it becomes dull. Note that point. Go back to the midline, percuss away from you to the point where it becomes dull. Ask the patient to turn towards you. Fluid moves away. You're going to percuss at that point. It becomes resonant. You're going to percuss towards the point where you think the fluid went until it becomes dull. Ask the patient to lie flat again. Fluid moves away, and then you show that it becomes resonant. It's not necessary to do the maneuver again on both sides. One side should be sufficient to demonstrate shifting dullness. If the patient has tense ascites, you may also demonstrate a fluid thrill, in which case you can ask usually another colleague, but if you have no one else to help you, the patient can also assist by dampening the transmission of impulses through the subcutaneous tissue by placing one hand perpendicular to the abdomen. You place your hand on the opposite side, and you're just going to lightly flick the abdomen in this direction and see if you can feel a fluid thrill or an impulse conducted through the tense ascites, which is picked up by the examining hand on the other side. So you're just going to lightly flick to see if you can pick up that fluid thrill. It's not going to be present in all cases of ascites. It usually has to be very tense ascites. After you've examined for ascitic fluid, you can examine for some other peripheral structures. So you can check for hernias. Hernias are usually either umbilical hernias or bilateral inguinal hernias. You can also have incisional hernias if there are any scars on the abdomen. Check for the umbilical hernia. You want to make sure you look for any defects which are obvious. You're going to palpate the area for any defects around the umbilicus. You can also check for a cough impulse. So ask the patient to just cough for me. And as the patient coughs, you look at the umbilicus to see if you're getting projection suggesting a hernia. If there is one, you can try and control it. You can put your hand at the point where there was an impulse and ask the patient to cough again and see if you can reduce that hernia or keep it controlled. Same thing applies to the umbilicus, to the inguinal area. Sorry, I'm going to expose you a little bit, and you're going to move the sheet down, look at the inguinal area, and ask the patient to cough again for me. And you look to see if there's an impulse on either side. If there's an impulse there, you palpate at the point where you thought there was an impulse and try and control it. Control it means to put your hand at the defect and prevent the hernia from coming up. If the hernia is already up, you can try and reduce it to see if it's a reducible hernia or not. As you're examining in the groin area as well, it's important to check for the presence of lymphadenopathy. So you take the opportunity to examine along the inguinal ligament bilaterally for inguinal lymphadenopathy, which basically would be done by palpation bimanually. Okay, so bear that in mind as well. You can also check for lymph nodes at the umbilicus by palpating for what's known as a sister Mary Joseph's nodule, which signifies a patient who has significant intra-abdominal malignancy, usually a gastric carcinoma. Those would be some of the things which we would expect that you would routinely do to examine for the abdomen. There are some other circumstances which may make you pay more attention to examining the abdomen. For example, if the patient has hepatomegaly, which was tender and soft, you may wonder if they have a pulsatile hepatomegaly as well. So it would be important at that point, if the liver is enlarged, to compress bimanually over the liver and just lightly compress, because it may be tender, to see if you're getting a pulsating movement of your hand. So if there's pulsation of the liver, it suggests the patient has tricuspid incompetence. So that would be a special thing to look for. The other thing you want to check for, if the patient has a mass in the left upper quadrant, is to see whether or not there is evidence of, if it's a spleen that's enlarged or the kidney that's enlarged. To differentiate between the two, it's important to try and get between the mass and the rib cage. So if you're able to palpate between the mass and find a space there, it suggests that this is the kidney and not the spleen. So that's one way of trying to distinguish between the kidney and the spleen on the left. You can also try and palpate for the notch on the spleen, and also there should be a band of resonance over the kidney, which is not felt over the spleen because of the presence of the colon. The other things you want to do for examination of the abdomen routinely is to auscultate. The auscultation usually would be one of the last things that you'll be doing. You're going to take your stethoscope and you want to listen for the presence of, first of all, any bowel sounds. You're going to listen for bowel sounds by placing a stethoscope anywhere on the abdomen. It doesn't have to be in more than one location. One is sufficient. Important thing is to give enough time to hear the actual bowel sounds. So once you listen, you keep it there for maybe 5 to 10 seconds, listening for the presence of bowel sounds. Apart from bowel sounds, you can also listen for the presence of renal artery stenosis or bruise. You're going to listen for renal artery stenosis by placing the stethoscope 2.5 centimeters laterally and superiorly from the umbilicus on both cases to listen for renal artery stenosis if you hear a bruit in either of these areas. So the stethoscope goes once here and then on this side. So the areas you auscultate will dependent on what you find. If there's hepatomegaly, you can listen over the liver for hepatic bruit, and you can listen over the spleen if it's enlarged as well. Other things which may be of interest in the abdomen, specifically if you find a pulsatile mass, you want to determine if it's an aneurysm, for example, then you can palpate the mass gently. You don't want to cause too much trauma to an aneurysm. So you're going to just compress the mass to see if it's pulsatile first of all, and then you also want to bimanually just compress laterally to see if the mass is expansile by demonstrating a movement of the hands this way. If the patient has an enlarged pelvic mass, then you may want to examine for that as well. If it's a bladder, you may want to percuss from above below to determine the extent of the mass. And in females, you may want to extend the examination, asking to do either vaginal examination and a pelvic exam. To conclude the basic abdominal examination, you also want to make sure that you request to examine the genitalia and also to do a rectal examination. So those would be the facets of the main abdominal examination. But bear in mind that having examined the abdomen, you also need to examine the peripheries for supporting features to assist your diagnosis. So starting at the fingertips bilaterally, you want to examine the hands. You're going to start at the tips and go more proximally. You want to look to see if there's any evidence of pallor of the nails, if there's any leukonychia or whiteness of the nails, if there are any traumatic lines in the nails. You want to check for the presence of clubbing, if there's gross clubbing, or if there's evidence of subtle clubbing, looking for loss of the nail bed angle. And you want to turn the hands over and look to see if there is icterus bilaterally. You want to compare for pallor on both sides. You want to look for wasting of the thenar and hypothenar eminences bilaterally. You want to look for the presence of Dupuytren's contracture, in particular for the abdomen. And as you know, this is thickening of the palmar fascia, and that runs in a longitudinal direction. So you're going to run your hand just laterally across the hand this way to see if there is thickening of that fold in patients of alcoholic liver disease or sometimes with trauma. Apart from examining the hands themselves, you want to do specific maneuvers. You ask the patient to just lift the hands like this and bring them back this way to check for the presence of asterixis. If the patient has a flapping tremor from hepatic failure, then they may have this kind of movement, which signifies asterixis. Apart from that, you want to check the patient's face, looking to see if they have icterus. Let's ask the patient to look down at the foot of the bed for me, and you look to see if there's any evidence of jaundice. Ask them to look up for me, check the mucous membranes to see if they're pink and moist. Ask the patient to open the mouth for me, stick the tongue out, looking again for icterus, looking at the pallor, looking at their salivary pool to see if they're adequately hydrated or not. You want to also check quickly for lymphadenopathy. Apart from inguinal lymph nodes, other lymph nodes which can be affected in abdominal examination of the supraclavicular nodes in particular in patients who have intra-abdominal pathologies, especially gastric cancers, the so-called Virchow's node. Apart from that, you want to examine for supporting features of chronic liver disease. So the patient may have pruritic scratch marks on the skin. They may have parotid gland enlargement, which you want to examine for. And they may also have bilateral gynecomastia. To check for gynecomastia, you want to do it not just by inspection, but also for palpation. Bear in mind that gynecomastia sometimes is very tender, so you want to just gently palpate the breast on both sides in the male to see if you actually palpate breast tissue and not just fat, to demonstrate gynecomastia in patients with chronic liver disease. Apart from that, you want to check the upper half of the abdomen and chest to see if there's evidence of dilated small veins or spider nevi suggesting portal hypertension in the setting of cirrhosis. Other things which may be a feature which you're not necessarily be able to examine for will be testicular atrophy and the presence of hepatic encephalopathy, which would require doing a mental status examination. When you move to the periphery of the patient, you also want to examine the feet. Again, you're looking for clubbing, which may be generalized. So you want to go down and look at the nail bed angle again to see if the patient has any evidence of clubbing. And then you want to check for peripheral edema. So just over the bony prominence, you want to just compress bilaterally to see if the patient has any pitting edema, which may signify intra-abdominal pathology as well. With regards to the abdominal examination, most of the features would be picked up on examination. There are a number of differentials which we're expected to discuss, and hopefully if any of the techniques which you're shown on the ward differ from this in any way, you should be able to discuss it with the managing consultant to try and resolve any differences. This is just a guide to help you to examine the system in some detail. Thank you.